CEO of 360 Public Affairs. And now that the recording started, let's do that again. Welcome. Hello, everyone. Good afternoon, good morning, wherever you are across Canada. Bill Dempster, working with the Canadian Organization for Rare Disorders. And today's webinar is on delivering on Canada's promise of value-based access to drugs for rare diseases. This is the culmination of a lot of work, and it's not just the culmination. This is a stepping stone toward future meetings and engagements with so many of you who are on the line and who have contributed to this over the last many years. I'm going to hand it over to walk through some opening level setting slides with Durhan Wong-Rieger. We have Dr. Francois Bernier in Alberta with us, who is going to present some conceptual slides around the structures for the centers of expertise. And Francois has been leading with a team of his colleagues across the country to help stand this up. And we're very grateful for the time that longtime management consultant and expert in organizational management, who is also a rare disease dad, Stephen Parrott, who is going to join us as well to help comment on how some of those structures are coming along. A couple of housekeeping items. Please use the chat. You'll see the chat panel there to provide comments and questions. Don't be shy throughout the presentations. Throw in your questions, and we'll find time to get back to them. And if we don't get to them today, we'll get back to you offline. Second, this webinar, as usual, is being recorded, and the recording will be on CORD's YouTube channel, and the slides will be on CORD's SlideShare channel. So keep an eye on that. And I think that's about it. I would maybe start by inviting Durhan, Francois, and Stephen to introduce yourselves briefly, and then we'll hit the slides running. So Durhan, everyone knows you, but over to you.
Hi, Durhan Wong-Rieger, President CEO of the Canadian Organization for Rare Disorders. And to echo Bill, I am so grateful that people are on this journey with us, because really this is what's going to make the difference in terms of our being able to convince the government's funding to be directed toward where we need it to be.
Excellent. Francois?
Oh, hi, I'm Francois Bernier. Sorry, I can't show my video, but I will later. I'm a clinical geneticist in Calgary and scientific director of Precision Health at the Alberta Children's Hospital Research Institute. Longstanding interest in advancing, this holistic model of improving care for patients with rare diseases across the age spectrum. So keen to be here and keen to see the whole field move forward. Great opportunities.
Thanks so much. And Stephen, if you're on the line as well. Stephen's going to jump in a bit later. I know he's been in transit, so we'll get Stephen on shortly. But over to you, Durhan, to help set us up for a great discussion.
Thank you very much. And again, we thank people for staying on. I really want to encourage people to use the chat line, actually, not only for questions, but also to introduce yourselves. So I think that is a great opportunity just for us to have for people to kind of be able to connect with each other. So yes, I think many of you have been on this journey with us, and hopefully you will be well aware of the background. But I thought we start a little bit with where we are now. What are some of the real challenges we're seeing along the way, and what we need to do collectively as a community now to continue to, I feel like we're kicking the can, and trying to keep it moving forward, which is a really sad analogy, but unfortunately seems to be that we need to build it bit by bit. So first slide there, Bill. So this is us. Those of you who have been involved with us, we're fundamentally a patient network and comprising of patient rare disease organizations, more than 100, and overall mandate to improve lives of people in Canada living with rare diseases. Next. Yeah, we're not going to belabor this. I think this is the starting point for us, and somewhat hopefully the starting point for the government, recognizing that these therapies for rare diseases, many of which are the only therapy available, many of them are life-saving, life-altering therapies, are not getting to Canada. And in some respects, not even getting to the starting line with Health Canada as the regulator compared to the European Medicines Agency, or certainly compared to the US FDA. So really only at the end of the day, 2/3 of those coming, and at even with the 2/3 coming to Canada to get approved, we get down to only about 1/3 that are actually funded and available to patients. So this is the tragedy when we look at where our rare disease strategy, our rare disease access is stuck. Next. So many of you have seen this before, so I won't belabor it. This just reiterates what I just said. We bring them to Canada. They only, again, about 2/3 get approved by the regulator. And then as you can see on the numbers going down the line, they begin to become increasingly challenging in terms of being able to get access. So same with EMA, FDA. Next slide. And this, of course, is the slide that I think many of us as patients are fully aware of, that even once they get to Canada, once they get an approval, only 7 out of 10 get reimbursed with the public plans, and taking up to 5 years. So think about a progressive disease, what happens in that intervening 5 years, especially for those diseases that are fast progressing. I used to say, think about kids, but we know for adults as well, this is a huge challenge. Next slide. So this was a comparison, and we bring it back in. This was a study that was done here in Canada, led by Dr. Liam Ward, to really look at how do we do any reimbursement compared to the European countries. And this really focuses on reimbursement. And as we can see, Ontario somewhat leads the pack, but they are far below what the access is in Europe. And again, this is, a real limit in terms of how our public system working in terms of supporting patients. We are, down the road. No, that's fine. Go next slide, Bill. Yeah, and you can see it here again. Where do we rank in Canada? Also in terms of the time to reimbursement. So not only don't we get the drugs here, we get them much, much later than many, many other comparable countries. Next slide. So this is something that we wanted to introduce, and we're hoping that we can actually drill into doing this exercise specifically for Canada. But really, at this point, we want to kind of show what the research has done. Much thanks to actually Nigel Rawson for bringing this particular study to our attention, though others have also been done. Important part of this slide, this was a study that was done with 24 rare diseases across a large number of countries, including Europe, did not include Canada. And what we saw here was their ability to take the diseases across all the disease groups, neurological, metabolic, hematological, immunological diseases, and congenital diseases. And what they did was to really look at, where are the costs in terms of patients with regard to these diseases. And what you can see, of course, is that the average cost for the patients, the burden of disease is really, a lot of it is based on, as much the indirect costs as they are direct costs. And it varies a bit by the disease category. So if you look at congenital disease, it's about half and half in terms of what are the direct costs, that is the actual cost of getting care for treatment, versus the indirect costs, which are the other costs that are borne by the family's lost income, the inability to continue to participate. And again, as we say, it depends a bit in terms of the area. Part of the challenge, as we know, is that these costs, in terms of the direct costs, can sometimes look a lot less because there are no treatments. So you get categories like metabolic or hematological, where in fact there are lots of treatments. The cost of treatment relative to, the other costs might be a lot bigger. But what we also know, and what the study really is able to show, is that the costs, increase. I think this is the starting line. A lack of treatment is associated with a 21.2% increase in total cost per patient per year. So if you don't give them access to treatment, they actually cost more than if they actually have access to treatment. This is the lesson that has to be driven home. And in fact, the mortality cost can be a whole lot higher as well. Next slide. So just continuing this, we can make these slides available. We can also make, you can see the reference to the study there on the bottom line. This is kind of what's included in the direct costs and the indirect costs and the mortality costs. And what we do know, as they said, was with this scenario analysis, is that in direct costs with treatment, on average, half of what it would cost, with treatment than without treatment. It costs more. In direct costs, the actual medical hospitalization professional services cost twice as much if you don't treat the patient appropriately than if you do. The indirect costs are the same thing, almost, the same ratio of 80-90% without treatment. And the mortality, of course, cost surprisingly, again, the same. If you treat them, they actually cost less even towards the end of life than they do if you don't treat them. This is a really important statement when we talk about the cost of treatment relative to the cost of hospitalization, cost to the family society without treatment. I mean, just from a pure economical point of view, we should be treating optimally. Next slide. So this has been our proposed pathway. This is not the time to belabor it. For those of you who can join us, we are planning a 2-day meeting, June 28th and 29th in Ottawa. Limited space for in-person, but we will have a virtual line if you're interested in terms of joining us for the 2 days virtually. What we're going to do is really drill down on the pathways that we've been talking about, including what would an alternative pathway look like in order for us to get to treatment as soon as possible. And this includes it. See, it starts with screening, including, having managed access to provide the therapies and being able to collect real world evidence. Next slide. So this is the strategy, as many of you know, that were announced with some $68 million for initiatives to going to research and to collecting real world evidence, and somewhat to ensure that we're going to have governance structure. The bulk of the monies, 1.4 billion, is allocated to provincial federal negotiations, bilateral agreements. It is really a struggle for us, and why we're doing these again is we have not heard from the government, from federal or provincial governments, that these negotiations are starting. We've not been included in any of the discussions. And as we say, the challenge is that maybe they're having the discussions without us and they're getting started. Maybe they are already moving on the government's first agenda item, which was to create a list of drugs that would be funded. If so, why aren't we at the table? Why aren't the patients who are most affected at the table? Why are we not being consulted? If they have not started, good grief, it's been months now since the strategy was announced. It is important that they get started, and we have presented them with almost a blueprint of what it takes to get started. So we find it unacceptable, unconscionable that we have heard nothing about how these negotiations are going on, or even when these negotiations have started or maybe beginning to start. So we will continue to develop what we think is the right system in the background, but at the end of the day, we need to make sure that this is going to be fully included and endorsed within that $1.4 billion that are going directly into drugs and to the support for screening, diagnosis, etc. Next slide. So this was our presentation before. What are the 3 pillars we're including? They have to go together. Centers of expertise, a designated drug strategy, and the research network. They're not 3 separate pillars. They are connected. One really depends on the other. We're going to get the optimal drugs. We have to have the rest of it. We need to have a data platform, is what you see under there is undergirding it. And quite frankly, the last part is patient engagement. So patients are here. We've been ready. We've been waiting. We've been proposing, solutions. We've been involving the community. We're not being included by those that are leading the implementation. Next slide. So at this point, I'm going to stop and I'm going to hand it over to Francois Bernier from Calgary, who's going to take us through the planning and thinking around these centers of expertise and putting the reality in terms of what we're trying to do and how this is going to support us in terms of rare diseases. So over to you, Francois.
Yeah, thanks, Darren. Yeah, first of all, I think, always kudos to Cord. I think we have an incredible group of leaders in Cord, but also the network that they bring together on these calls who are all championing the same objective, right? Which is improving health, wellness, and outcomes for patients across the life spectrum with rare diseases. And in the sort of academic clinical community and in the industry communities, we're all keen for the same objective. So how do we move this to action? And for those of you who've been on Cord calls or meetings, you've seen various versions of these. Leon Ward has presented one, Craig Campbell I have, and many of the centers we work on are trying to develop their own understanding of how to be holistic, but also comprehensive in addressing the needs of, that we have heard from our patient and community partners, but also within the system and our industry partners. So that involves a continuum of activities that go from integrating care, research, and building capacity. So these have to be integrated across everything we do with specific priorities, which you saw in the previous slide, maybe redirected a little bit here to ensure that we have an accurate diagnosis. We have capacity building occurring in Canada, all for one initiatives, building off of Care for Rare initiatives, a number of diagnostic programs to improve access to diagnosis, but also registries tied to that. So how do we understand the patient has an accurate diagnosis and is contactable, and they can contact us and we can contact them. So those are all for one initiatives. Clearly, I think the right-hand corner of improving access to innovative therapies across the spectrum of novel molecules, novel therapies, curative therapies, bioengineering solutions, all kinds of things, but particularly drug access, right? Which is such a challenge for a field that's moving so fast. And then the last one there, which is always hard for us to know how to name it, you'll see on a different slide, which is, how do we improve care? And care can be all kinds of things. It can be addressing mental health, social challenges, medical challenges across the continuum of really complex needs that many of our families and communities face. And how do we start addressing those in a more systematic way? It can be everything from clinical care protocols to ways of assessing challenges, patient-reported outcomes, PREMS prompts, and all these things that are so important. So if we move to the next slide, it's nice to have these conceptual frameworks, but then we want to move to something that was, how do we actually start looking at our goals at the top, the outcomes of all of this, and then how do these pillars actually get built out? So these are the three pillars. So if you look at the kind of programs of phenotyping and an undiagnosed disease program, moving to diagnostics and registries, which is really the care goal of good, timely access to diagnostic testing. The middle pillar is going to be a big one. We know it's important. We know it's crucial. So preclinical pipeline of novel therapies, including non-pharmacological therapies, but pharmacological therapies, of course. Moving into a clinical trial network, there's some funding through CIHR to enable that network, which we're all engaging as national community to be competitive for and to create a single network and single proposal that really it has that goal of enabling access to therapies. And there are some challenges in this pillar that Cord has addressed nicely and Durhane was speaking to early on. And then, this care management, family community centered care and support, holistic care support, and enabling those best practices. And we would view the centers of RD expertise as comprehensively being ready to enable all of these in their centers and then partnered across Canada and partnered internationally. So patient engagement, data building capacity, and knowledge mobilization, EDI is underpinning principles. So this becomes a framework for us to move this forward. I think the Ottawa meetings can be critical now because we want to move to kind of talking to action. So how would we put together, if you go to maybe next slide, Not sure if I do governance, someone else does, but governance framework for this. So actually, how would we set it up with a secretariat to oversee it, a steering committee to bring knowledge to action, resources and a network team that would actually do this, and then start bringing these pillars together and actually launch it. And I think instead of kicking the can down the road, and I know we're all doing it and we're all trying to do our best, I think we should put some hard timelines on to actually launching the network and then looking at how we can resource it. So we're keen to see this move and in partnership. And I will say patients and community organizations need to be at the center of everything we do.
Thanks so much, Francois. And I believe we have Stephen with us, Stephen Parrott, and you didn't get a chance to introduce yourself earlier, so now is your chance and your initial thoughts on this, although you've been giving weeks and actually many hours of your time. So all the best in consolidating some of that expertise and thought for where Francois has brought us to so far on the structure, Stephen.
Well, thanks very much, and good afternoon, everybody. I agree with Francois's remarks as far as kudos to CORD for bringing us all together, as well as to drive the federal government to set aside this money. So it's all good. It's all moving in the right direction. I think that this diagram gives you an idea of one idea, a concept that we can work from. I believe, and I'm not sure what the other thoughts are on the phone, but I believe that the Secretariat has to have some major say in what the steering committee recommends, and then the recommendations of the steering committee informed by advisory committees, the drug access committee, the working groups, and the pillar groups, really giving clear direction to the network coordination team. I think that that's a real winning strategy. I am just going backwards, I'm the chair of the Canadian VHL Alliance. So that's my volunteer job, but professionally, I work on business consulting as well as management objectives, and working with leadership teams to make sure that their strategies turn into action and their actions turn into results. So this is something I'm quite passionate about. And I think that we have a really unique opportunity to ensure that the folks that are really responsible for this, both the federal government as well as the provincial governments, have a major say in how this is brought together, as well as the patient community and the groups that are represented on the screen here. So those are my initial thoughts on this. Durian, Bill, I'd really be interested, as well as Francois, in your thoughts on this type of structure.
Rohan, why don't you kick it off?
Yeah, I mean, I am just delighted, first of all, with your participation and bringing in that kind of expertise. We're very lucky, and not just in Canada, but across the globe, where we have patients and parents who actually have expertise in really, various areas that can bring it into kind of furthering an agenda. I think it's critical. As we go back, and you saw what we were talking about, right? It is essential that we have this kind of a framework implemented in order to assure that we've got access to the best medicines. And Stephen, you're a parent. You want to see these therapies here, but nobody wants to see them funded without having good screening and diagnosis, without having a really good scientific committee. So I think this is essential. I think for us in Canada, we've had the opportunity to see what's happening over in Europe with the European reference networks. We see what's happening in the US with the centers of excellence there. And there are across the globe, I think you just came from Latin America, I forgot exactly where you were, but Brazil has one of the premier, rare disease centers that they have put in place there, which again provides different models for how do we work. But I am thrilled with the fact that we are now creating this Made in Canada model that fits what our system is like now, What are the opportunities to work together, notwithstanding the huge challenges, right? What about the funding? What about cross-center, support? What about, the ability to move patients if we need to, never mind just referencing, right? What about the regulatory challenges if we've got, different provinces that have different kinds of regulations in terms of how they actually are able to manage patients? So all of these things we need to work on, but all of those are actually small details when we compare it to the major kind of a network we've got here. So, I mean, I think, so I'm really pleased to see where we are. And Francois, I mean, maybe I'll print it back over to you, commenting on what Stephen says. Like, we've had the question asked to us before, how much of this is already here? Are we building this from scratch? Are we building this just from a conceptual model?
Yeah, I actually think that a lot of it is here, but it needs the Secretariat and an active steering committee to pull the partnerships into a consistent dialogue, and that's CORD, the academic clinical centers, and industry, and do so in a coordinated way. And I think that pulling the first part, we're going to talk about next steps at the June meeting, is, I think we really need to describe this. And CORD has a fantastic document that spells so much of this out. But, what are now terms of reference and governance? Like, that's always the kicker. If you don't understand your governance, your terms of reference that guides this, it's hard to move it forward. And then who's responsible? And I think identifying a secretary and a steering committee that is responsible to move this forward in partnership, obviously with the key stakeholders, and we can't say enough of the importance of CORD and its members here. But also the healthcare system, the research institutes who are going to guide all of this stuff, and then, organizations like MyCERN, et cetera, et cetera. So I think establishing the governance, clear terms of reference, and getting it going, and finding some resources initially to do so are going to be critical steps. This is a made in Canada solution. I don't think we can be in the era end where we tell people you must have all these things or you can't play in the sandbox. Like, everyone needs to be in the sandbox. We have to all be in this. Patients need access. Patients need their centers to be part of this. So we need to enable growth and success, and then deal with the regulatory challenges in a systematic way. So I think I'm kind of reiterating the need for us to just establish and start moving. And then I think there's opportunities which not represented here. And we have another version that we've been working on. This will go through multiple rounds of partnerships with those rare disease networks. So I think we could establish very strong partnerships with, NORD, with the ERNs, and potentially very embedded partnerships, depending on how close our missions align and what that could look like. So we aren't starting from fresh, but we're bringing a fresh approach to it, but leveraging the international partnerships that are going to be crucial to our success. And the third one is, where do we have resources and programs that are already existing? So there's a federal funding. We have One Child Every Child that's going to bring some resources to this table. So this is a federally funded CFREF on the aspirations of one child should be available to all children, right? So, and it has a rare disease focus in theme 2, which is precision health for complex and rare diseases, and has significant resources to build national and international infrastructure. And Durhane kindly was a supporter of that. So maybe I'll stop there. I think it's a great starting point. Let's just move it to action. And that now means writing out what are all these committees doing, what's the overall governance framework, and what resources do we have to actually put on the table and populate this.
Sorry, go ahead, Bernard. Where do you want to take it?
No, you go ahead, Bill.
I was just going to say there was a couple of final slides that we wanted to share with folks regarding what governments, not just the federal government, which you showed earlier, are moving towards, that I think will help enable some of this infrastructure to move forward. And a lot of this is actually based on the foundational Canada's Rare Disease Strategy. I dare anyone to Google that, and there is actually only one that you'll find really, because the federal one is a rare disease drug strategy. Eventually, we might take that out and have a truly holistic federal national approach, but for now, it's cord that it's withstood the test of time in terms of the 5 pillars of that are all essential, and those are actually woven into what you're trying to stand up, Durhan, and everyone is actually. And if people missed it, we did 2 webinars last week in French and English to talk about what RQMO is also doing in Quebec. There's also an Ipsos Canada survey that was presented earlier this year, and we've done other webinars on that to really take the pulse of what Canadians affected by rare diseases want from their leaders. So CORD, I understand, is looking forward to continuing to engage the community, patients and caregivers, but also next steps, clinicians, developers, payers, policymakers, you name it, because it does take a full community with all the stakeholders to actually bring this to action. The good news is that, especially in Quebec, and we spent more time on this last week to talk about what's happening with their framework, and now they have an action plan to stand this up in Quebec on raising awareness and training of health professionals, easy and equitable access to diagnosis, care, and services, which includes treatments, and promoting research, innovation, and data gathering. Ontario had clear recommendations from working group in 2017. There has been some vision papers that have come forward. The current health minister, Sylvia Jones, has expressed support, and recently the official opposition NDP has tabled a private members bill to say, hey, dust off those recommendations from 2017 and move forward and implement them. So this is happening. I bring this up because Terry from British Columbia asked, what's going on in British Columbia? So I think that all of the folks on the line who are across the country have an opportunity to go to your governments and say, hey, take a look at Quebec's strategy. We've actually translated that into English. Look at what was proposed in Ontario and get each of your provincial governments to bring forward rare disease strategies that will help implement and support what CORD and everyone is trying to do. Durhan, how are we going to tie this together? And what would you say to Terry, who's asking about British Columbia, for example?
What are we asking in British Columbia? I'm sorry, I don't know the exact question.
Terry just had a really good question. Heard nothing yet regarding the plan from the BC Ministry of Health. And there's really, as you said right off the bat, you're not hearing that much either coming out of these discussions, but it sounds like BC is crickets, for example.
Okay, no, everybody's cricket. And I think this is our challenge, except for Quebec. And I think this is the big challenge. We just came back from, as you know, from Alberta and Edmonton, meeting with, people at the provincial health. We're hopefully going to be in Calgary middle of next month to be able to meet with people again. I think the challenge is we've reached out to British Columbia, and, all we have heard back from British Columbia, quite frankly, is that they are very strongly supportive of what we're doing, but that's full stop. There are no indications. I have heard, and I'm going to put it out there, even though it's more than rumor, but it's less than, kind of a substantiation. But, us, we need to kind of put it out there. We hear the provinces are talking to each other. We hear that there are, in fact, some negotiations even going on with the feds. But as we say, we have not been invited to the table, so we have no idea exactly what is being proposed. The other thing we are concerned about is we have heard that they're not even on the same page. So this is a big concern. I mean, the fact is the federal government has said we're going to do this in bilaterals, but those bilaterals are not going to be one-offs. And they are asking that the first step is going to be the agreement to have a list of drugs that all the provinces will buy into. So I'm a little concerned that they've set this up in such a way that it's almost, impossible to achieve in any kind of a timely fashion. And it totally misses, I think, what we have been asking for, and that is Don't do drugs without infrastructure. Don't do, and we've given them the infrastructure. I mean, Francois just presented it. This is what it needs. And we've got, other projects that are in place in order to look beyond that. So I think that's the important thing. We are very concerned that, the provinces do need to be brought into the equation. So Terry, I would say to you is that what we need to do, and we've been saying it, but we need to put it into action, is that we need to get into the provinces, get people like you to the table, and that we need to start hosting these roundtables in the provinces, and that we need to invite, the representatives from the health systems and from the government to the table to say, it's unconscionable. We got $1.4 billion sitting there and nobody is spending it. And in the meantime, patients are not getting access. And when patients are not getting access, it actually, as the socioeconomic study shows, it's costing us more as well as patients' lives. So Terry, I hear what you're saying. And I think we need to, if you've got, capacity, I think what you want to do is, you say you work in, province, I think, reaching out to the ministry and being able to say, where are we? But, love to kind of connect with you as well to say, can we host this, in the provinces? Because I think unless we're there, we are grateful to the NDP for having put together a private members bill, and just resurrecting, right, what was there, and to say, come on, get on with it, and, so I think that's, great. And if every province were to go to what Quebec has done and say, here, we have a strategy. Can you fund our strategy? Hey, we would not be opposed to that so long as we were all working together.
Durhan, briefly to build on that, I want to put a pin in some opportunities that are coming up in the next few weeks. All of the premiers of the provinces and the territories are meeting in Winnipeg. So on July 10th to 12th. So if anyone on the line is either based in Winnipeg or planning to go around there, now that's on the day of, but we all know that the agendas for these big intergovernmental meetings are established weeks and sometimes months in advance. So one action item, I think, for CORD and this group is to put up the flag and to send a note into all of the premiers to say, as your officials are talking to the federal government, keep this concept in mind and ask for support for this as well, and get going on your own provincial plans, a la Quebec and emerging Ontario. So that's just one sort of near-term thing that I think that CORD can help lead on. I don't know if other people have any thoughts on that.
I think that's a great idea. I know that I've already written to my MP and my MPP to try and ask for action, and I'm reaching out to my contacts. So I think that's a great idea. I think everyone should take the opportunity to encourage their provincial government to apply for this money for sure. If I might just change subjects just slightly and suggest that Francois had mentioned that there's a number of initiatives underway already. And in some provinces I know, for example, for VHL, there's a VHL clinic in BC, that could be an example of a budding center of expertise. I'm wondering if it might be a good use of our time to, Francois and maybe a small committee, just put together a structure so that we can put a shared document out to ask people to fill in where they have some components that are already in place. One of the strategies that we've used with some associations is to go where the energy is. If Quebec has a strategy and they've got a number of boxes filled in, then let's help them, because the first one through the gate is going to be the toughest one. But once that's done and the precedent's set about how this money is accessed, it will open the floodgates, probably, because provinces don't want to be left behind, and they don't want to be shut out if the money gets allocated before they get their application in. So just as a suggestion, maybe we can talk about, trying to identify a structure so people can communicate what they have in place now.
So, Durhan, that might go back to you or Francois on, you've hosted like Leanne Ward on rare bone disorders, the folks in hemophilia, and Francois, what are you seeing in terms of what's out there already?
Yeah, I think we're on the same page. Svenja and Heather on the call today, and this morning we were just talking about two things, and they overlap here. One of them is a bit of an asset mapping, right? Surveying across Canada, seeing, where do we have strengths and gaps, and also asking centers, as CORD has done with its membership, what are the challenges? I think we've done a fair amount of that, but I think the other component is, can we establish, in a sense, a playbook, a set of kind of criteria, rules, standards, not that you have to meet to be a part of the network, but that we would aspire to, right? That we could take to our federal governments, take to our health system, take to our provincial ministries and say, hey, here's an example of the types of things that would really enable better value in the healthcare system, better outcomes for our patients. But it's going to take resources in these domains. We have to be able to do outcomes. We need to have care close to home. What are the things that, instead of us all rewriting it? So, and that was part of the strategy document that CORD wrote, but can we refresh that and say, okay, here's some resources that you can use in your establishment of a center, or in the improvement of your center, or in your dialogue with stakeholders, right? Particularly ministries. And I'm sure CORD has a lot of these resources. So again, it's becoming a bit more systematic. I'm a huge fan. Everyone has heard it, but I'm a huge fan of the Start Small, Act Fast. You can try and boil the ocean here, and we're just going to be here in a year talking about the same thing. So let's just start. Let's figure out where we can get some momentum, get the flywheel going. And you're right, that could be focusing on a particular model or a center or a place that's already doing things, places where there are resources that we can enable, and yeah. Let's go.
I think that
Yeah,
we have a couple of great systems in Canada already. I mean, our pediatric systems, our CHEOs and sick kids and so forth, they're centers of expertise now. And so if we can leverage the folks in those groups to help us, just put the structure out there so that we can then fill it in and find out where the energy is, as you say, Francois. And then we can compare that to international models. Once we have that, then let's make sure that we aren't reinventing the wheel. And if there's something that we can learn from an international model, then that's the stage to do it at. And then, and as we're doing that, people are still building things, so we can add to it, and we can try and help people that are in motion now. Let's get behind some activities that are already in play. There's Quebec, just for example. I think that from what I've heard, from a provincial level, they are the ones furthest ahead on this. But I'm not sure whether that's the case. We haven't queried every province.
Yeah, Quebec has a design and a framework, right? But the implementation still is to come. And I think, as we heard last week as well, the amount of money is allocated for it is not going to really kind of achieve. I think what Francois is saying, though, I love hearing, because if we can do that asset net, we already have most of the pediatric centers here. They're all part of it. I think the question we're going to ask in June, at the end of the month, is how do we integrate sort of multi-disease comprehensive care, like the children's hospitals, with the disease-specific clusters. So it's a bit of a European model, which is the, European reference networks, which are disease-specific, and the American model, US model, which is really around centers of expertise. And I think, as Francois says, we have the guidelines that the US use, so it lists out the categories. It would make a good starting point. They use it as an application. They say you must apply, and we will see how well you meet these guidelines. I think our question is, what are they? And as Francois says, where are we now? What's aspirational? The same as the European reference networks. They have basic standards, and the question for us is, where are we on those? What do we need to do? I think the big question after that, though, is how do we make it happen? And this is where some of that resourcing is coming. I like the fact that, Francois, you were saying, we need to look at where industry plays a role here. How do we bring industry in it? They have a huge opportunity to help us in terms of funding the framework, helping us fund what we're doing and moving it forward. And I know they are quite keen to do so. We need to set it up in such a way that there is the ability to kind of provide that kind of support without, kind of taking it away from kind of what is going to be available. So yeah, we're gonna, I'm actually quite excited, honestly, Bill, I feel like we've been working for 8 years to get us to this point where we first created the model and saying, okay, let's roll it out, let's keep creeping it along. And then we thought when the feds came out with the strategy that, okay, that was an opportunity for them to drop a bunch of money into it. They didn't exactly do that. The monies are there, but they're in the provinces. So part of what Terry is saying, I think is important, and that is how do we shape some of that money that's in those bilaterals to be directed to these centers? And I think that's a really important question. So I think others are asking, 2 other questions in here that are really valuable for us to think about. Calvin Yip says, I'm an academic researcher. Where do we get monies? Is there any monies for research? We said research, but right now the research monies are allocated in a very specific way towards a network for clinical trials and for certain kinds of gene therapy development. But shouldn't we actually have research funds that will support, academic research, in rare diseases? I think including training, where's that going to be? And I think we need to figure out. And then Risa maybe asked an important question is, what about, 2 elements, right? What about the more peer group support? How do we make sure? Again, we had hoped that some of this could go to, how do we support it? Patient organizations, we all say patient center, we say the patient groups are the backbone of what we do. We look at people like you, Steve, and we say, yes, go for it. And then we say, but we don't really want to give you any money to do it, so you go ahead and do it alongside of everything else you're doing. And if you can get some money, it's good for you, but don't get too much from industry, because then we'll kind of look at you sideways and say, are you being bought by industry? So we've put patient groups into a position where we want them to be able to be that support, but we are giving them, I would say negative resources sometimes in terms of do it. How do we build that in? So, yeah.
The patient support group center of expertise is one of the things that's near and dear to my heart. And, being able to share agreements agreements and basically bylaws that patient support groups can adopt that clearly identify how and when to engage industry so that it is very transparent and sustainable. Those types of things can be shared across groups like mine.
Yeah.
So looking forward to seeing some of that.
So participants here, I know you identify, both Heather and Svenja as in our group. I mean, maybe we can invite them to kind of jump into the discussion from their perspective. I know you've come in and you've been working with some of this lead group, but anything that you would like to kind of add in terms of what you see, in terms of current or next steps?
So that's a note. Here's Heather. Super.
Yeah, thanks, Jerhain. No, I think Francois summarized the work nicely. I think it's really about building a cohesive network that incorporates research, that takes advantage of both money coming from the federal government towards healthcare, as well as money coming towards research. Because research, and again, this is my bias, it's my background, but research is sort of underpinning everything that's going to come up clinically. Your best research centers tend to be your best clinical care centers. So I would suggest, rather than seeing research as a separate pillar, it's really the foundation of the center's model.
Durhan, just building on that, I want to go back to one of the challenges or issues that you laid down earlier around the drug list. I heard a great podcast from somebody that we hear from regularly, Andre Picard. He reflected on 40 years of health journalism. I'm going to actually throw it into the chat if anyone wants to listen to it. He said that with the advent of precision medicine, and he mentioned rare disorders in particular, the concept of binary formularies is is probably something that we need to revisit, where it's, you know, an automatic yes or no, depending on where you are for this specific stage of you know, the disease progression or diagnosis or whatever. Now, do you think that if the Rare Disease Centers of Excellence gets set up, it will actually be a responsible answer to the challenge that is going to be coming from some governments and some academics potentially around the need for sustainability? We have to be able to say no to some medicines that are coming through. Is this going to answer some of those tough questions, do you think?
I think the goal that we're all saying, and you know, I chair the Global Rare Disease International. This is the same question we have everywhere, right? How do we build towards sustainability? And I think this is something that is critical in terms of how do we actually frame the funding and support. Honest to gosh, you look at that socioeconomic study, and when we say it costs twice as much in direct costs if we don't treat the patient than it does to treat the patients, I think the question is not how do we kind of get, you know, this, but how do we make it, as you say, sustainable? How do we move some of that money from the back end to the front end? Not that we won't still have back end, but if we can begin to allocate that. And that was what some of the things we were hoping this 1.4 billion was all about, right? How do we take some of that funding, even in the drugs end? We know this drug is going to cost a lot right up front, but it's going to have tremendous benefit. How do we actually have that bolus of monies up front? Well, hell, we got $1.4 billion. Cannot some of that go to that? How do we get diagnostics in terms of getting, you know, we have a great model. It's, you know, Francois mentioned in terms of the all for one. How do we make sure that's sustainable? You know, so that people who need to get a genomic sequencing in order to diagnose. So it's moving that, you know, around, as you say. So yes, I think this is a model that has to be built for sustainability. And this is also where I want to invite partners to come in. You know, interestingly enough, if you look at the European models on the national reference networks, if people have not, you know, aren't too familiar with them, they're across all of the EU, they're funded a lot by the EU, et cetera. There have not been the opportunities for public partnerships in there. And they actually are, in many of them, really bemoaning that fact that they have not built into provision. How do we make it more sustainable? Research. I mean, who has the biggest incentive to invest in research coming back from industry? So I think it's a huge opportunity for us, as we're saying, is to build our model in such a way, takes advantage of the uniqueness we've got, but also uses the best practice learnings, right? And I think that's I mean, it sounds a little bit pie in the sky, a little bit, you know, euphemistic that we're just going to do it that way. But when I see people like, you know, Francois and Heather and Sanya, you know, coming to the table, and I look at what Kim and the others are doing, I'm saying we have such a great start here in Canada that if we can really leverage it, it feels a little bit sometimes like a bootstrapping operation, but you know what? We've been doing that all along. So I think it is the opportunity to kind of make sure, though, that as we're thinking about building this, we're thinking about sustainability. I mean, why do you think we keep saying don't fund the list of drugs? That's not sustainable. You can suck up all that money in a heartbeat and you will not be better off. Fund it in a way that it is sustainable. The other thing I will say quickly is in some of our conversations across the provinces, you know, this whole thing of FOMO, fear of missing out. You were talking about, okay, all the money is going to go to Quebec and get it. I see the other. I hear provinces saying, are we going to invest in a bilateral? And then after 3 years, the feds are going to pull out and we're going to be left holding the bag. We've committed to a whole bunch of resources. We've committed to, you know, establishing, and then we're certainly going to find that we don't get that sustaining monies. So I think we need to make sure as we're building this, that it's built for sustainability. I mean, the best examples are, you know, that very early, you know, Fabry's Managed Access, right? It's a 10-year drug fund plan. The feds after 3 years said, okay, we're done, over to you. I mean, they kind of announced ahead of time that they were going to do that, but I think nobody expected they would do that, but they did. So I'm not, you know, kind of crying foul before it happens, and we hear the reassurances, but I don't I do not fault the provinces for saying, if I go into this, am I going to be left with a whole bunch of things I committed to, and we're not going to have, department monies.
Can we pose that as part of the steering committee's objectives to say, if we involve the Secretariat and they're a key member of the steering committee, that sustainability is built into the metrics and into the priorities that we set?
It should be a guiding principle, I think, Stephen. It shouldn't be necessarily something that is, it is an overarching need to happen. One of the issues with rare we find is that it's not always a clear-cut, obvious case. When you have an opportunity to save a life or to help somebody, then it's a red light on sustainability if it costs X number of dollars. So as a guiding principle overall, for sure, as a green light, red light, I'd have some concerns about that, because sometimes we just don't know. And the advantage of retrospective analyses like the one that you shared earlier, Erhan, is, somebody's crunching on something. I hope it sounds like the chips are good. Thank you for muting yourself. I think it's an important guiding principle overall. We just have to be careful about how it's applied. I think that's the main point. We're trying to save these underwater people in a submersible submarine off the coast of Newfoundland and Labrador. Full stops being pulled for that. And every few years something like this happens, right? Like the Thai soccer team, and we are going to do whatever we need to do to help them out. And I want a similar attitude to be brought to rare sometimes.
Yeah, good point.
This is the problem though, Bill, and I think this is where we need to go away from, right? We're again having these global discussions around the same thing. To what degree is a rare disease a rule of rescue? Are we rescuing patients who have high unmet needs and it's a one-off? Because we built that to begin with, right? There was only, a handful of treatments for a handful of very small number of patients. So hell yeah, let's spend the monies and let's rescue them. That is not a model for sustainability. I mean, if we had, Thai soccer team that was caught in a cave every other week, you can imagine how tired people would be after a very short time. If we had some, Marines that went down and say, oh yeah, we're just going to keep exploration, and we had 24 of them on the bottom of the ocean, people would be throwing up their hands in despair. So I think we need to, as we've all said, feel for sustainability. And I think that's the big challenge, right? How do we put Stephen, this is why we got you. You don't advise your companies to say, here's your one shot, go ahead, go up in flames. And, I'm here and I'm going to steer you in a path, but hey, 2 years from now, and if you go down, it ain't my fault. That's not it, right? We're there still for sustainability. So I think, good call, right? But it is, yeah.
Let's get some insurance folks out too, to be able to spread risk. I think that's really important. And maybe we should, when we do the asset mapping, I'm thinking back to what you said earlier, Francois. There was something that got announced last week in Boston around a deal done between Amgen and Horizon Health Network to help some cancer patients get access to some novel therapeutics there. And it's a true risk sharing agreement. It will be funded access in parallel while it goes through CADTH and the PCPA. So we've got some Canadian examples of the managed access or the access pathways that we should probably pull into that stream as well, because we can do this, right? This is doable. I think that's what we want to leave people with.
So I think we're just about the end of our time. I really want to thank certainly Francois and Stephen for their engagement there, to Heather and Svenja for having put together some of those backgrounds and are going to be helping us lead the discussions next week. Some of the hard questions you've raised here, we're actually going to try to come to grips with in those 2-day sessions. If you're interested and you would like to participate, I think we're kind of out of space in this tiny little room, Bill, that we thought in the beginning would be big enough, but as it turns out, we may be busting out the seams of. But this is not the last meeting we will have, obviously. We're hoping this group will come together, kick off for us a really, implementation plan that we can start to move forward. We do want to get into the different provinces. So Terry and others that are in the different provinces, we really would want you to come and set forth with us, and let's see if we can do this together. And beyond that, then what are some of the ways that we can measure progress and build for sustainability? I think that's critically, important, not just for, this strategy, but for, for the patients as well. So thanks again to everybody. Bill, any last thanks? But thanks to Bill as well, always for his huge support in terms of bringing this
Yeah.
together.
Yeah, anytime and all the time. That's what it is when it comes to what you need, what the community needs. And I just want to give a shout out to all the people in the chat and the delegates who came on. We're meeting some new people who want to get involved with CORD. As you said, 100+ members. Maybe there's some new members of CORD that want to get involved. And there are a couple of the questions and points in there. We might, if we didn't get to it, we'll get back to you later. Keep an eye on SlideShare and on YouTube for slides and the video recording, and we'll get that out to everyone who registered. And we'll see some of you next week, and then all of you at the next webinar. So thank you again, Durhan. Steve, it's great to have you on. I know you were in transit, so thanks for making it work.
Yeah, thanks so much for Stephen. I know you had to jump into some hole in the airport lounge or something to make this happen. So we can't thank you enough.
Thank you. Thanks, folks.
Bye-bye.
Thanks. We'll see you soon. Bye-bye.
Bye.